it. So now cell required it. But one you have few questions for 5-minute discussion. Any from postgraduate side? Because aggressively we have already circulated. I think most of them you have covered. Frequently asked questions. Yes. Madam,
in patients who are taking steroid due to conditions like ITP or autoimmune hemolytic
Then you cannot avoid steroid.
if they develop hyperglycemia, means if a previously
drug-induced hyperglycemia and management. Your question.
Should it be managed with oral hypoglycemic initiative or directly?
Usually, when the patient uses steroid, they need insulin because it is so much delayed that most of the time they need insulin. But if it can be controlled with oral hypoglycemics, then it's okay because steroid actually causes post-receptor binding defect. So it basically causes insulin resistance. So if it is managed by insulin sensitizers, theoretically it is possible. But actually the blood sugar level is so deteriorates after use of high level of steroids. And if you want to combat that hyperglycemia very quickly, we usually take liquid insulin.
Yes.
Diabetic patient well controlled on oral hypoglycemics, they develop diabetic retinopathy, say early diabetic retinopathy. Is it logical to shift them straight to insulin or continue with oral
insulin?
No, retinopathy itself is not that microvascular complication which needs insulin all the time. If the patient has already developed retinopathy, then use of insulin does not
prevent
that. It can or tight glycemic control can only halt the progression of the disease, but it cannot reverse it. So it's better to aim at tight control, whatever may be the case. Because we have so many good oral hypoglycemic agents nowadays. I had a debate just one week back whether triple OAT should be used or insulin, and I was in favor of triple OAT at that time because there are so many drugs and they are addressing the pathophysiology. But I have given one picture in such a way that even use of oral hypoglycemic agents, if they can control the blood sugar level, it can be given because ultimately it is the goal which we have to reach, not the way through which we are proceeding.
One important question related to diabetes and traveling. Okay, diabetes and traveling. Suppose all of our relatives are somewhat who want to go from particularly either one is the aeroplane, one is the route through the railway route. So aeroplane route, particularly suppose foreign country going, must be have a certified doctor certificate that they are having insulin pain. So you must advise them to keep his prescription. Number one. Number two, regarding the cartridge, how many cartridges you will keep with this required. Otherwise, most of the airport center have this guideline regarding diabetes. One. And regarding your Indian Railway, we don't have a diet provision regarding diabetes yet, even in Rajdhani and this till now, because we are discussing, suppose this is also legal issues that those who are in insulin, but out of them they are discarding some portion and rest they are eating. That is the way for Indian Railways are going. But some countries have their guidelines for diabetes. And as I said, surgery regarding any gangrene patient, 500 sugar, want to operate for that surgical side. What should be planned? Whether you want to fit on acrapid or aspartate?
Yes, one thing is that in the surgical side, by the surgeons, usually the sliding scale is used. But actually the recommendation is that there is no such recommendation for using sliding scale. Because in sliding scale what we are doing, actually we are seeing a point, at a point of time we are observing the blood sugar level, and we on the basis of that we are changing the insulin, next insulin. But what we actually have to do, you have to adjust the previous dose of insulin. So sliding scale is actually not recommended. But in case of when the patient is well controlled with diabetes, then we may start with regular insulin. If it is controlled, then we can proceed. But if it is not controlled, then
make debate, sir, and it is
Madam, in unconscious patient?
Yes.
Unconscious patient with hyperglycemia, how?
unconscious patient with severe hyperglycemia, we even see insulin infusion. So we will always go for regular insulin in a particular scale, and for that reason there is a sliding scale. 480 we suppose.
Most of the international center,
Because unconscious patient, the patient cannot take meal-related insulin. Then insulin infusion pump is the...
If that message, one message that if the time now came that sliding scale is now a outdated procedure. Although we are practically using, it is time has come to keep the nailed coffin. Most of the center has now started this sliding, but still practically we are using. Infusion is the ideal choice. always in intensive control.
Now, how to calibrate? Suppose a patient on
Yearly
having
checkup,
high
yearly,
problems,
2 hourly and 4 hourly sugar
and
checkup.
it becomes sliding scale.
There are no.
Sliding scale is different. No, we are using infusion. The only
Yeah.
problem with using infusion insulin is you have to monitor it much more
Much frequently.
carefully. So you cannot sometimes use it for every patient
Yes,
because
I
of
understood, sir.
logistics.
But time this
But
is
yes,
massive,
for
yes.
seriously ill patients, we are using infusion insulin with close
In ICU
monitoring.
sector,
But for
seriously ill patients-
all patients, sometimes not possible only because of logistical
Actually, after
reasons.
1 or 2 days, the total insulin requirement,
We can
daily
calculate.
requirement can be
Yes.
calculated, and from that we can adjust. But for the first
So my
couple of
question
days,
is
it is really
regarding SGLT receptor antagonist.
SGLT new drug.
These are, I mean, reduce the absorption of glucose in kidney. So this
How it
will
acts?
it lead to dehydration, osmotic dehydration
These
as
are
we
certain problems, although it is not documented. I have no experience because here we
It is
have no
basically
experience
glucose
with
reabsorption
these
and
drugs.
PCT.
But theoretically there is more chance of UTI and glycosuria is there, so there is increased
And,
urinary frequency.
will it
But
lead to
that basically
exacerbation?
dehydration in a conscious patient can be corrected at any moment. It will take more fluid.
Will it exacerbate the symptoms of diabetes like polyuria?
Yes,
and
urinary frequency will be increased, I have already told you. Because there will be glycosuria.
What about patients on parenteral nutrition? So
Yes.
the insulin is to be
And-
given
and-
separately as an infusion or can be put a part
It's
of it
better to
separately as an infusion?
The diabetes and impotency, ED, regarding the ED and diabetes, a big challenge for that. Mind it, it is a CAD equivalent. So never use with the nitrate with sildenafil. It is a deadly combination. People will die. Suppose those on monotate and nitrate, and they are using this for the ED as a sildenafil. It is absolutely controversial.
We always ask for this, whether the patient is taking nitrogen.
So that is also, so we should insert to that. Thank you, ma'am. Thank you to all and for your nice